د لوی بخونکي او سپېڅلي څښتن تعالی په نامه. Good afternoon to all doctors. Welcome. My name is Dr. Cطاء وقار. I'm consultant ophthalmic and phaco surgeon at Amiri Medical Complex, Ophthalmology Department. Our today's session will be regarding diabetic retinopathy, and this is a very unique topic. Inshallah, we will discuss that what will be our objectives, aims from today's session. We will know the introduction, a brief introduction of diabetes, then a brief introduction of pathogenesis of diabetic retinopathy, diagnostic methods that we have in how to diagnose diabetic retinopathy, and classification, because classification is so important in diabetic retinopathy, because every patient has different approach and diagnosis, treatment modality, and at the end complications. In a nutshell, at least we have to know these four things. We have to recognize diabetic retinopathy, we have to classify diabetic retinopathy and different retinopathy levels, and identify patients who need treatment, because sometimes patients don't need any kind of treatment, just we are asking for follow-up, close follow-up. And the patient who need treatment, and we have to advise and increase awareness of treatment methods, that which modality we have. Before who has a diabetic patient in their family? 1, 2, 3, 4, 5, 6. And if it's not more personal, who is diabetic? 1. So this is for all of us, especially who has a diabetic patient in their family or a person who has diabetes. So this is one question. For example, after the diagnosis of diabetes has been made, how often should a 35-year-old patient eye be examined? Every 12 months, every 6 months, every 2 years, every 5 years? Anyone from trainee? Every year. For example, you have diagnosed today one 35-year-old patient, you were advised that you have to go after 12 months. Okay, good. On immediate, you have to refer patient to ophthalmology department for diabetic retinopathy screening, and then according to the severity we have to decide. These are 3 cases which has a different approach. Anyone who can read this loud, because it will be more relevant. Actual patient will be like this. Good.
He has a 20-year history of type 2 diabetes with poor control HbA1c 14% and a severe hyperlipidemia. On examination, visual acuity in the right eye was reduced, while the left eye remained relatively preserved. Fundus evaluation of the both eyes showed multiple microaneurysms, clot and blood hemorrhages, cotton spot, and hard exudates in the posterior pole. What is the diagnosis and the plan?
Okay. Good. So this is a patient in fundus image 1. There is a little bit good view, but in the B, patient has decreased vision, and due to that the patient has decreased vision, and this is the OCT of the patients. So we have another cases also, but we will skip that. The patient number 1, just I will go in detail later. This patient needs just anti-VEGF, which is a vascular endothelial growth factor. And this is the case number 2. We will not go in that. This patient need pan-retinal photocoagulation and also anti-VEGF. This is the diabetic retinopathy which has also vitreous hemorrhage. We are calling high risk PDR. We have a good view, and we will go for pan-retinal photocoagulation. And this is NVD, NVE, we will come later. This is the case number 3. This is a very severe patient which need surgical treatment. Okay. Introduction of diabetes mellitus. Nowadays 246 million people around the world that have diabetes mellitus, which will be doubled in 2030, in next 5 years. And most of these is in the working age population that we have here. For example, from 20 to 64 years old. And we have two types of diabetes mellitus. You know better than that. One is juvenile onset type 1, or another is adult onset type 2. If you have diagnosed type 1 diabetes mellitus, you have to advise for the parents that within 5 years they have to start diabetic retinopathy screening. Because if the patient is younger, due to growth hormone or other factors, they are safe. But if the patient reach 10 years, in one literature they are showing 10 years, there will be some kind of changes in the retina, but some literature is saying that it will be 15 years. After 15 years there will be some kind of changes. But type 1 diabetes most commonly it present with decay, polyuria, polydipsia, like that, and type 2 is incidental, which will manifest as fatigue or some kind of above symptoms like polyuria. What kind of complication we have from diabetes as a general? There will be more MI 2 to 5 times, stroke 2 times, that will be more common in diabetic patient, and also peripheral vascular disease will be more common. And microvascular complication will be nephropathy, which is related to nephrology, and also neuropathy. An ophthalmic complication, what will occur in the patient who has diabetes, which is very relevant? It varies on type 1 or 2, which kind of diabetes patient have. It has some independent risk factors. For example, duration. If the patient has for a long time diabetes mellitus, for example, a patient who has for 10 years, another patient for 20 years, there will be more severe finding in patient who has for long time diabetes mellitus. Or hypertension, glycemic control is so important. For example, if a patient who has HbA1c 7.5, but he has for a long time, for 10 years, 15 years, diabetes mellitus, but he has a good control, there will be no severe finding on any kind of complication in the retina. Hyperlipidemia is the independent risk factors, and also nephropathy and pregnancy. If you have diagnosed type 1 diabetes retinopathy, and type 1 retinopathy, sometime at the initial 5 years complication is rare, but will occur after 10 or 15 years, which I have mentioned previously. But after 15 years, there will be some cases. I have seen myself more patient, not here, but there during my residency, that a 15-year-old girl, she presented with type 1 diabetes mellitus, and she has not controlled well. She had she was bilaterally blind. We have done multiple surgeries for that. Just we have reversed some of her vision because she was not controlling her HbA1c in a 15-year-old patient. And type 2 retinopathy present diabetic retinopathy finding when we are doing the first diabetic retinopathy screening. For example, you have diagnosed today, you are referring patient to ophthalmology clinic, and 20% of patient there will be some kind of diabetic retinopathy changes. But it will raise when to 60% after 15 years. What is the most common cause of diabetes decreasing vision in diabetic patient? That is diabetic macular edema. Most patients are asymptomatic. When they are presenting to us, there will be a lot of changes in the periphery of the retina, but he will be not aware. But when there is decreasing vision due to diabetic, from where we have a 90% of vision, which is the macula, if there is elevation, if there is edema, patient will come. When we are doing the fundoscopy, when we are doing OCT, patient will have decreased visions. The commonest cause of that. And also a patient who has diabetes, there will be early cataract than other patient. And also ocular ischemic syndrome will occur more common. Anterior ischemic optic neuropathy will occur more common, and orbital infection like orbital cellulitis or other kind. And cranial nerve paralysis, maybe you have seen more. For example, third nerve palsy, patient will have ptosis, extraocular movement will be defective, that will be restricted, and sixth nerve palsy, that is more common in the diabetic patient. And what we are doing for that, we are just wait and watch, and when we are doing good control of diabetes mellitus, it will recover. So diagnosis, you know better that that is fasting blood sugar, glucose tolerance test, and HbA1c more than 6.4. This is our basic things, pathogenesis of diabetic retinopathy. If you just know these pathogenesis from today session, it will be more. It is more rewarding. The main pathogenesis occlusion, number one. From the arterial side, there will be basement membrane thickening, endothelial cell damage, okay, RBC changes, platelet thickness increased. There will be ischemia to the periphery of the retina, and patient will have hypoxia, okay. Due to one this will one is occlusion, another is leakage. For example, there will be small outpouching of the venules, and these are very leaky. We have parasites around the vessels, and there will be loss of parasite. There will be leakage of the multiple contents from the blood, which is lipids and proteins, and that we will see in the fundus as exudates. When there is leakage, when there is occlusion, patient will have ischemia. If there is ischemia, as a body response, body will have VEGF, vascular endothelial growth factors. What is that? They are making a new vessels. When they are making a new vessel, that new vessel is not as a normal vessels that we have in our own body. That is so fragile. Every time that is the risk, it will rupture. When it rupture, there will be vitreous hemorrhage. If there is vitreous hemorrhage, like normal, we don't have, like suddenly we have lost the electricity, that things will occur. Inshallah, we will come. This is the diabetic retinopathy. Microvascular occlusion, number one. Retinal capillary non-perfusion, ischemia, arteriovenous shunt will occur, and then new vascularization will occur. When these new vascularization, that is the advanced stage of diabetic retinopathy. Inshallah, we will come in classification. The same things, oxidative stress due to VEGF, microaneurysm leakage, hemorrhage will occur. These are new vessels, okay, and extra new vascularization will occur, which will leak. Okay, this is a normal fundus. We have optic nerve, okay. This is the macula. This area is so important for us in diabetic patient, and we have to save this area by every price, because 90% of vision comes from here. This whole area is called macula, and this is fovea, and small is foveola. This is normal. Diagnosis methods. We have different kind of diagnostic method. One of that is direct ophthalmoscope. This one, very simple, very indispensable, and we can do examination at the bedside with this. How we are using this? If we off the light, it is good, but sometimes we are dilating. If we dilate the pupil, it is very good. When we are doing examination, please, yes, if you demonstrate, it will be very good. Please. When you are doing examination with this instrument, which is called direct ophthalmoscope, it should be at your right hand. Patient will be well dilated, okay. From here you have to on. When you are doing right eye examination, this should be at your right hand, and right hand, my right eye, patient right eye. And you have to counsel the patient, especially if the opposite gender, because we are very nearing to the patient as possible. We have to near. For example, like in this patient, first of all, we are calling this distant direct ophthalmoscopy from 25 centimeter. Just we are seeing here red reflex. Red reflex mean we are giving patient give a lot of information to us. It means that the retina is clear, that the cornea is clear, there is no cataract, and there is no vitreous hemorrhage. Just with this one examination, we can achieve this more information. Then we will near very slowly to the patient, and first of all we will find the optic disc. Okay, then we are following the vessels. Sometimes we are not finding the optic disc. If you find any vessels, you have to follow the vessels, and you will find at the end optic disc. Then if you are doing left eye examination, in the left eye, this ophthalmoscope should be in your left hand, my left eye, patient left eye. It is very easy approach. Thank you. We have dilated some patient in ICU. If someone want, we have two ophthalmoscope. At the end of the session, they can do there. Okay. So this is the practitioner side, because sometimes when a person who is very beginner, they are doing another practitioner side and bro wrist वगैरह. This is the we will not go in detail more. Another method that we are using in ophthalmology department, this is indirect. That was direct. We don't need any kind of instrument. This is direct with slit lamp with 90 diopter lens. This one. This is the 90 diopter lens we are using in ophthalmology department. It gives more area. That one just give one optic disc 6 degree, but this give us to 45 degree, 90 degree area of the fundus. This is the indirect ophthalmoscope which we are wearing like a helmet. It is rechargeable. We have to here, and this will be in your pocket, and you have to on from here. Okay. And we are using this 20 diopter lens, which is a larger lens, and it will give more area to us. This one. We are using this in our department. Sometimes patient can sit, and sometimes it can lie down. And we are using in our ophthalmology department a cutting edge technology for the diagnosing of the diabetic retinopathy. What it means, we have this machine which is called fundus camera. Fundus camera, patient don't need that we have to dilate. Just with one click, patient come, we are taking the picture, and we are giving a document to the patient. We have here, and we have taken some picture. This. It is a non-invasive methods that we can diagnose diabetic retinopathy. Even you don't need to dilate the pupil. This is a very advanced machine which this machine give a small area, but this is advanced machine which give a very large area from the whole retina. I will show you later. We have this machine. Okay, an advanced machine is this one, and a very advanced which is Optos ultra wide field machine. It gives the whole retina, then about 200 degree of retina. We can just with a one capture we can see. This is the fundus camera we have, and this is a binocular indirect ophthalmoscope, this one, and we have in our ophthalmology department this with 90 diopter slit lamp. So this machine we have, this is called OCT, ocular coherence tomography, we have in our ophthalmology department. We are using this machine for the diagnosing of diabetic macular edema, which is the most common cause of sight loss in the diabetic patient. Also, we are using this machine for the purpose of age-related macular degeneration, which is the #1 cause in the Western population. We can diagnose with this machine early or moderate form or very advanced form of glaucoma, which is a blinding condition. This is our department machine. My assistant, Mr. Jamil. Actually, this OCT is ocular coherence tomography. It is a histological examination of the retina. Just we are taking the histology of the patient. It's just like that. We have a 10-layer in retina. We are calling this neurosensor retina and RPE, retinal pigment epithelium. So in the living human, we cannot take the retina because it is a very precious organ. So we are doing with this machine, just like this histological examination. If there is any kind of increased in thickness, if there is cysts, we can diagnose with this above machine, which is a very sensitive machine. This is one of our patient by the name of Ismatullah. He was a 25-year-old male patient. He came from Mazar Sharif about 1 month back or more than that, with decreased vision bilaterally without any kind of history. Some private hospitals, they have advised. So this is I will show you. This is increase in the retinal thickness. This is the right eye. This is the left eye. You can see here it is more increased in the 275 and 355. There was physiological problem, decreased vision, and anatomical problem. There was what? Retinal thickness was increased. They came in private hospital. They have advised that we are giving intravitreal anti-VEGF injections. According to the protocol, we are advising for 3 to 6 month medical treatment. If that is not responding, then we are going for the injection. Alhamdulillah, we have started the treatment for that, and after 20 days, he came with this. Physiologically, his vision was 6/6, and anatomically, this is his retina. Again, that we have taken with our OCT machine. And about 3 days back, he contacted me from Dubai. He was very happy. This is teleophthalmology. Teleophthalmology, just with our own camera, we can take the picture in the far periphery, for example, in Badakhshan, in Rozgan, and we have to send to a qualified doctor. If there is any kind of problem in that, they can diagnose. This is with 20 diopter lens. You are putting in the mobile, and you are taking the pictures of that, and you are sending. This is also they are sending the picture for the teleophthalmology, and they are interpreting. If there is any kind of problem, for example, need any kind of intervention, they will ask that refer the patient or do the examination or any kind of investigation for that. Diagnosis of diabetic retinopathy with artificial intelligence. This is a new modality which has been used in some countries nowadays. For example, you have taken the picture with with the fundus camera like this, and you are uploading your picture to the AI model, and there, if that is gradable, okay, they will ask you referable, non-referable diabetic retinopathy. Referable means that you have to refer this patient to one of the tertiary care center. If that is not referable, it is no need. In this AI model, there is no need for a doctors. But if that is not gradable, repeat imaging and dilate the pupil, and they will ask AI, artificial intelligence will give you that, don't repeat the picture. This is the classification, important. If there is no apparent retinopathy, we have mild in PDR. Mild in PDR means that there will be some kind of lesions in the periphery, which is called microaneurysm, outpouching of the vessels. Microaneurysm only moderate NPDR. NPDR is so important, this N. It is not very dangerous. No proliferation of the new vessels. There will be microaneurysm associated with fewer than 20 intraretinal hemorrhage. Okay, but if there is severe NPDR means that we are calling 4-to-1 rules. 4-to-1 rules means that the patient will have in all 4 quadrant 20 retinal hemorrhage in every quadrant, 2 venous bleeding. I will show you later what is venous bleeding, and 1 ERMA. In this case, or PDR is the very dangerous form. PDR means that already there some vessels is formed which is leaky. Every time there is a risk of bleeding of that. We have to do something now. That is normal to moderate. No diabetic retinopathy, mild in PDR, moderate PDR, and this is critical. Proliferative diabetic retinopathy and severe diabetic retinopathy. I will come later what is severe. This one. This is advanced diabetic eye disease. Advanced diabetic eye disease means that the patient.
Are these changes reversible from grade 3 to 1?
It depends on the patient. For example, if we do good diabetic control, if the patient has a good control on diet, exercise, and also ophthalmological good intervention, it is reversible. For example, from PDR we can reverse. I will show you, inshallah. I will show you.
So it's not the end stage?
No. Advanced diabetic eye disease that I have showed, this is just classification. We will come to the treatment. In advanced diabetic eye disease, there will be vitreous hemorrhage, there will be tractional retinal detachment. You know that we have a retina, it is attached with the vitreous. I bring with myself this.
How many years the patient goes from normal to PDR?
It depends on the factors.
The diabetes is not controlled.
It depends on the patient. I have seen the patient who has for 30 years diabetes, but they have a good control in HbA1c, good control on the hypertension, and also good control on the hyperlipidemia. I have not seen any kind of changes, even microaneurysm. But I have seen patients who just for 10 years and there's advanced changes. You know that this is the vitreous body or vitreous gel. If this is a very jelly and more concentrated body fluid, and if there is a bleeding in that, we cannot see anything. But sometimes in advanced diabetic retinopathy, what occurs? There is bleeding. This is the retina. It will take the retina with yourself. We are calling tractional retinal detachment. Traction will occur. Tractional, TRD, tractional retinal detachment. We have different kind of retinal detachment. One of that is tractional retinal detachment. So this is part of advanced diabetic eye disease, and we are going for the management of this patient are different because we are going for the surgical retina. There will be microaneurysm and blood hemorrhage and ERMA. The patient will have vitreous hemorrhage like this. So for the management of diabetic retinopathy, what we can do? First of all, glycemic control. That is so important. If we don't control glycemia, everything can occur. It is a multidisciplinary approach. Not just ophthalmologist can do anything. Me as ophthalmologist, you as a physician, and a patient. We told that what is the most common cause of decreased vision in diabetic patient? That is diabetic macular edema. If I'm injecting one injection which is 0.05 milliliter anti-VEGF Avastin injection, it cannot do anything. it cannot reverse the vascularization unless there is no good glycemic control. How? What is the recommendation for the glycemic control? That is between 6.5 and 7.5 ideal. Or if the patient is very old, if there is risk of hypoglycemia, then we can raise our, for example, until 8, no problem, because there will be more other factors. So I bring this for demonstration purpose. If there is some kind of diabetic macular edema, this patient has already has diabetic macular edema. Okay, I am just removing 1 cup of water from this as ophthalmologist. I have removed, okay, with my injection. But this is the physician. For example, he is not controlling well his patient. Again, he is okay. This fluid will decrease or increase. Never it will decrease. Or if the patient is not careful, this is the patient. Patient is not careful about his daily routines. He is not exercising well. Yes, yes. And this is the patient. I have just removed 1 cup, but they have put a lot of water there. At the end, there will be loss of the vision. The treatment will be not successful. And never this water will decrease. So it is a multidisciplinary approach. We have different trials. One of that is DCCT, Diabetic Control and Complication Trial, which has been done for 30 years. And what was the result or summary of this DCCT? In DCCT, they showed that result indicate that most youth with type 1 diabetes mellitus, if you intensively control glycemia, there will be less diabetic retinopathy changes, there will be less microalbuminuria if you intensively control. If not, so more diabetic retinopathy changes and more microalbuminuria. About 2 weeks back, there was one pediatrician in my office. He came, he told me that one of my daughter, she is 10-year-old now, she has type 1 diabetes mellitus. I have asked him that you have done any kind of diabetic retinopathy screening. He told me no. Pediatrician, own daughter, what we can expect from others. And this is also this is the summary of that DCCT. For example, if the HbA1c is 6, there will be less progression of diabetic retinopathy. But if the HbA1c is 10, exponential diabetic retinopathy, exponential neuropathy, microalbuminuria. So in the type 1 diabetes, it is must. If we decreasing HbA1c by 1%, how we are decreasing the deaths? How we are diabetes related deaths? 21%, MI by 14%, and also microvascular complication by 43%, and amputation or death by 43%, just with 1% glycemia control. And this is another study which has been done in UK, which is called UK prospective diabetic study. It showed that was for type 1 diabetes. This is for type 2. They have showed that if you control good glucose or good BP control, good controls, it will decrease the complication of diabetes by 12%, death by 10%, and vascular disease by 25%. If you good control mean 144 versus 154. It will decrease the diabetic related complication by 25%, by 32%, 44%, and 37%. stroke by 44%, just BP control. What is the new recommendation regarding, I will come later, this is the new recommendation for management of diabetic retinopathy. Previously they were asking that BP should be less than 140, but now they are saying that there is some kind of complication, we have to decrease more BP. It should be less than 130. And cholesterol control is must. Regarding of statin, if the patient has diabetic retinopathy, I am advising myself fenofibrate 200 milligram OD for every patient, just to reverse that changes which has been in the retina. Sometimes I am advising to the patient, and when they are coming back and they are saying to me that physician, stop that we have already give you statin. Okay, statin is okay, we are not saying, but fenofibrate is very effective for the diabetic retinopathy.
Why?
Research showed.
Why?
Why? Because we have their leakage. From the leakage there is there will be a lot of exudates, and we want to reverse that exudate which is from the lipid in the retina. And I have there is one trial which has been done on the fenofibrate. I have not mentioned here.
Like what's happening in the diabetic, this lipidemia, triglyceride is very high.
Yes.
But no point.
Yes.
This fenofibrate, they are covering this triglyceride more than the study, other this parameters. So I don't know whether in the study they did this lipid profile and they like randomized, they did different class in which this triglyceride is high. I don't know whether
No,
did
they have not mentioned
even
in.
the normal triglyceride. I don't know whether they checked it with the normal triglyceride and they have given the fenofibrate. Is there any different effect or not?
If there is diabetic retinopathy changes, we are advising not for every patient.
No, this I'm telling you. They would have summarized in the different group in which triglyceride is high and they have given the fenofibrate. And another group in which triglyceride is normal, they have given the fenofibrate. Then they should compare that one. So that
Inshallah, I will share that study with you.
Yeah, please.
Okay, inshallah, I will share with you. Another is renal function. We have to control microalbuminuria, which is related to nephrology, and lifestyle modifications like smoking cessation, weight control, exercise at least 30 minutes per day, and obs gynecology. Anyone from obstetric and gynecology? Okay. In pregnant women who has pre-existing diabetes mellitus, at the start of their gestation they have to do the diabetic retinopathy screening. If there is any kind of changes there, they have to do the next visit at 16 week. If there is no changes at the start, they have to go in the third trimester on 28 week. It is must, because pregnancy it exacerbates the diabetic retinopathy. So screening, what is screening? Screening is the systemic testing of population or subgroup for asymptomatic disease or ignored disease like diabetes mellitus. The only way that we can save the vision of diabetic patient is screening. You know that in Spain the diabetes mellitus incidence is increasing, but the diabetic related blindness incidence is decreasing. Why? Due to good screening. So this is the NPDR, which is not NPDR. They have their own stage: mild, moderate, severe, very severe. PDR, which is severe NPDR. And high risk PDR. High risk PDR means that there will be NVD, new vessels on the disc, new vessels elsewhere. I will show you. If there is high risk PDR, for example, there is new vessels on the disc, new vessels elsewhere around the retina. The recommendation is, if there is a good view of the retina, you have to go for same day PRP, pan-retinal photocoagulation or laser. Because if you ask the patient to leave the diabetic the ophthalmology clinic, maybe after 1 day, 1 hour, 1 week, there will be leakage or there will be vitreous hemorrhage. Then we are doing what for that? Surgical treatment. Now we are doing laser treatment. 4-to-1 rule, that is in the severe 4-to-1 rule. 4-to-1 means that there will be in 4 quadrant, we have 4 quadrant of the retina. There will be in all 4 quadrant there will be dot blot hemorrhages. In 2 quadrant there will be venous bleeding, and the venous bleeding. Yes. Venous bleeding, be like tasbih manand. And in the 1 quadrant there will be IRMA, intraretinal microvascular aneurysm. It occurs due to more severe ischemia. Okay, there is one structure I will show you. For example, the patient has diabetic macular edema, or there is any kind of systemic changes. We are advising at the first stage these Avastin, which we have in our department, to decrease the diabetic macular edema and reverse that VEGF, vascular endothelial growth factor, which occur due to ischemia. We want to give some anti-VEGF. This is the one class, Dr. Shakib, you are using more for the colon cancer, but we are using, it is non-FDA approved, but the effect is comparable with aflibercept. With not with aflibercept, it's comparable with Patizra, ranibizumab. Bevacizumab is comparable with ranibizumab. This one. This is very expensive medicine. This is less expensive. Excuse me? It is non-FDA approved. You know that if it is not FDA approved, it doesn't mean that it don't have any kind of effect around the world, especially in the developing countries, using since a lot of years, 20 or more than that. But you know that FDA is not. Okay, so we have Avastin, Elia, ranibizumab, which is more expensive, and this is the new one. This is the we are injecting 0.05 milliliter every month, like this, and directly to the vitreous. This is the we are injecting, and I am not going in the technical side of that. So why we are discussing diabetic retinopathy? Because challenge to diagnose it, tendency to delay treatment. Most patient I have seen here, they have high risk PDR, and they have vitreous hemorrhage, they have decreased vision, they have new vessel on the disc, new vessels elsewhere. I am asking that you have to go for injection. They are saying that no, 2-3 months back they have injected one injection to me, there was no benefit from that, I don't want to inject another. We have to counsel the patient that this injection is not improving your vision, it is just regressing the vision, it just saving your vision. Because tendency to delay treatment. Sometimes treatment is inadequate, just we are injecting anti-VEGF. Anti-VEGF is not appropriate, okay, in the severe disease. We have to do what? PRP, laser. I will come at the end. And disease progression with visual loss will occur. We have different kind of vascular endothelial growth factor. VEGF-A, which is more common in our eyes. VEGF-B, VEGF-C, VEGF-D, and placenta growth factors. This bevacizumab that we are using, this just stop this VEGF-A. Not all, but aflibercept and other ones, they are inhibiting VEGF-A and placenta growth factor also. This is the superiority of this one, which is called Elia. If the patient can afford, we can provide for them here also. So this is what is these bevacizumab? These are antibodies. Bevacizumab is monoclonal antibody, complete antibody, okay, and ranibizumab is a fragment antibody. VEGF, they are attached. But this aflibercept, this is the fusion protein. Just it goes like this and covering all the VEGF, not allowing to produce more new vessels. Because of that, it has good effect. And also aflibercept, sometimes we are injecting after 2 months, 3 months. It decreases the frequency. We have to inject bevacizumab every month. This after 2 to 3 months. This machine, this is so important. Sir, we need your attention on this. This is photocoagulators. And we can save more vision on this. How? This is a green laser. If the patient has no diabetic macular edema, but the patient has more severe changes in the periphery, we are doing this. This is the technical part. I am not going for that we are doing 3 sessions, session number 1, session number 2 and session number 3, how much burns. This one, for example, we have to save this area. Okay, normal retina you have seen previously, we are coming and burning, ablating the retina. The peripheral retina, we are converting the peripheral retina, this we are converting, I will come, we are converting, this is the whole retina. Okay, this is ischemic retina, we are converting to anoxic retina. Because if we convert this peripheral retina to anoxic retina, what we are doing, it will not produce more VEGF, there will be no more ischemia, and if there are new vessels, that will regress automatically. If that is in the NVE mean, new vessels elsewhere here. NVD mean new vessels on the disc, NVD. It will regress. We have to save this macula. And by any mistake, we have to avoid to not burn this area, because 90% of vision come from here. You know what is this? Is very regular, okay, and this is very irregular. This is the old modality, this is the new modality. This is the new modality. We are calling this patron laser. Okay, you have to select different modality like this, and according to your wish, it will ablate the peripheral retina. We are the commercial name is Pascal laser. You have to select here like that. This is a Pascal laser versus conventional laser for treatment of diabetic retinopathy. If you are doing one monospot laser, or if you are doing another which is the patron laser. The Pascal photocoagulator is safe, the new one, rapid, effective, with rapid learning and had short exposure time. Pascal one is better one.
This Pascal, this is 2011. So we have the new one.
No, not new one. Even we don't have this Pascal until now in Afghanistan. We have a monospot here, which is more. It take more time when you are performing.
No, in the other part of the world, do you have any?
No, not this. This was the recent one, Pascal.
Last 11, last 25 years.
No,
why 15
no.
years,
No. I will show you this. This one. This is we have Nidec machine, Vexi. I have forwarded to sir already. We very regularly ablate the peripheral retina and save the central retina to avoid the reversible blindness from the diabetic retinopathy. And we have two kinds in the retina. We have two kinds of fellowship. One is called medical retina, another is surgical retina. From the center I have done residency, that was a retina center, and I have seen more patient. And my thesis topic was comparative study of intravitreal bevacizumab and intravitreal diclofenac in the treatment of diabetic macular edema. We have compared bevacizumab with diclofenac. The effect was same because of inflammation, and also in some cases diclofenac was good for the persistent macular edema. But bevacizumab is good, it is effective, it is reliable. I'm not saying that my research is it is a whole protocol that we have to start for diclofenac. What is the importance? We are not allowing the patient of the diabetic retinopathy that we will send patient to surgical retina. We are doing Avastin, then laser. If there is advanced diabetic eye disease like this, then we are sending patient for the surgical retina. We are doing a procedure which by the name of PPV, pars plana vitrectomy, and we are removing the whole vitreous which is there is bleeding in that, and also if there is retinal detachment, we are reattach that retina. And how much will be the success rate of this? It depends on the patient. Okay, sometimes we are achieving anatomical success. We have detached retina, we will attach, but there will be no physiological success, very less, sometimes less than 30 or 20%. This is the conclusion of that. We have ischemia, we have inflammation in diabetic retinopathy, we have blood retinal barrier breakdown, and due to that there is diabetic retinal disease. Home taking message from today's session will be: who is the front line soldier? Dr. Govind? The front line soldier are physicians, because patients are presenting to ophthalmology clinic when there is advanced diabetic retinopathy. So general awareness is so important, because we have to advise for the patient the importance of the HbA1c and other factors you know better. In Spain, diabetes mellitus incidence is increased, but diabetic retinopathy incidence is decreased due to good control of the diabetic retinopathy screening. You know that our most society is religious, and if we are just giving some kind of things from our religion point, they will know very good. وَلَا تَلْقُوا بِأَيْدِيكُمْ إِلَّا تَحْلُكَ, and make not your own hand contribute to destruction. Don't destruct yourself by your own hand. خود را به دست خود به هلاکت نیفکنید. If you are blinding yourself, not caring to yourself, no one will harm. You will be harmed. At the end, this is just for the young doctors. If you want to earn more, what we have to do? No. From the last, I want to have some answers. If you want to earn more, just guess. What you have to do? Huh? Okay. Another one? Good. Another one? Cryptocurrency. If you want to earn more, you have to learn more. It's just like that. The more you earn, the more you learn, okay? The more you earn. So it was just an encouraging for the continuous medical educations. If we don't have continuous medical education, if we don't sharp our saw, if we don't update ourselves, after 5 years, our knowledge will be very old. So I hope you have enjoyed that. We have one disease which is called branch retinal vein occlusion in central retinal vein occlusion. Yes, central retinal vein occlusion. If the patient has branch retinal vein occlusion, we are advising for that patient, if there is diabetic macular edema, we are advising anti-VEGF. Okay, if the patient has branch retinal vein occlusion or central retinal vein occlusion, if there is new vascular glaucoma, new vessel formation on rubeosis, we are calling iris on the new vessels on the iris, okay, then we are ablating the peripheral retina to stop the VEGF. If the patient don't have diabetic retinopathy, I have seen myself here about 2 months or 1.5 months back, one patient came from Ghor. He had hypertension, bilateral branch retinal vein occlusion in one eye, in another eye, and there was macular edema. I have advised we have to inject this, and then we will go for the laser, but he has not accepted, and after 3 months, inshallah, he will come with raised eye OP, intraocular pressure, with glaucoma, with rubeosis, and very poor prognosis. Okay? Manana dera ziyat. Assalamu alaikum.